everybody. This is Gian Piero Palermo from New York. First of all, I would like to thank Dr. Aziz, Dr. Schrager, as well as all the organizers for this kind invitation and the opportunity to share with you our experience on sperm selection. So we know everybody in the last few years since the WHO 2010 have been coming to adoption, we measure all our assessment through this parameter. So other than the ancillary, such as abstinence, volume, and viscosity, we look mainly at concentration and morphology. Motility when present, otherwise we look at viability, or we look at presence of other cell or agglutination. Now, this is not always the case. In certain situations, we have to perform an extensive semen analysis. That means we have to search somewhat in order to retrieve some spermatozoa. That's because after centrifugation we don't see any sperm, then we have to go to a high-speed centrifugation up to 3000 G. And then with a physician request, of course, we explain then there are additional costs because involve at least a search for 1 hour or more, several andrologists or embryologists, and at least 2 dishes at 400 time magnification. The dish are those they use for the ICSI, and in this case, instead of putting the oocyte in the peripheral droplet, we put the spermatozoa and we search. We go dish after dish to exhaustion of the specimen, and then that's what we identify if we are lucky to see one spermatozoa. So on this line of work, we actually performed a study. We did a paper in 2014 on PLOS ONE, where we described the so-called extreme ICSI. And so we did an analysis where we used as a control the specimen with ejaculated or testicular specimen, where we spent only half an hour. And then thereafter, a time interval, all the way for the ejaculated almost up to 4 hours, for the testicular up to 6.5 hours, we actually went forward in order to identify some spermatozoa. And when you look here for the ejaculated, the standard search here identify up to, as you see on the right here, only about 3 spermatozoa, then the power is to the third. So if you then look for the spermatozoa identifying the actual dish, say 1 to 3 after 3 hours search, or just 1 if we look for motile. And then we inject about 1,000 spermatozoa for the study group versus 31,000 for the control. These are the spermatozoa that we use for the control and those for the study group. Then for the testicular, also with a standard search up to 3 hours, identify 1 to 4 spermatozoa, and the motile barely 1. We injected about 3,000 oocyte. We compared to 7,000 as control. Again, these are the control spermatozoa, and those are the one injected in the study. These are the spermatozoa actually utilized for the ejaculated specimen, and these from the testicular specimen. As you can see, they're very different from the ideal spermatozoa that we look for. So if you look at the fertilization, you see the control of 75%, but the study group between 34 and 53%. The same for the testicular, 58% lower fertilization in general for testicular spermatozoa. But the fertilization was steady all the way to 25% over 3 hours. That means that when we identify a spermatozoa, there was a chance of fertilization. We look at the clinical pregnancy rate. When I say clinical pregnancy rate throughout this talk, I refer to the presence of at least 1 fetal heartbeat. And you see that although we searched for 3 hours, still we were able to get a decent pregnancy rate. That means that as long as we were able to inject oocyte and create embryo, we had a chance of pregnancy. A similar study situation was for the testicular, from 40 to 23%, so very much clinically acceptable. We tried to do this study in the beginning to see how long we have to search in order then to decide to stop the search. But apparently, as long as it takes to identify spermatozoa, it is worth it because we'll be rewarded with a chance of pregnancy. When we look at spermatozoa, it is important to consider the genomic integrity. We know that spermatozoa have a unique nucleus where the DNA is hypercoiled around core of protamine. There are, however, a linker region in between the toroid of protamine where the residual DNA are the residual histone has still presence. And these the linker region are prone to damage. And in fact, in the normal ejaculate or normal individual, the range between 16 and 20%. While in the past was considered just a kind of an imperfection of the coiling system, now we understand that the area of DNA that can be promptly transcribed once the spermatozoa enters the eggs. However, to assess the integrity of this linker region, we can use different assays. We have here to the left the COMET assay. This is considered the most sensitive. And the alkaline COMET assay can actually recognize single and double-strand DNA breakage, while the neutral only specifically identify the double-strand DNA. The tunnel assay here on the top right identifies both single and double-strand. The sperm COMET instructional assay below can actually differentiate also between single and double-strand with this anchored in the orange portion of the assay. So we know that sperm COMET fragmentation has a positive correlation, direct correlation with maternal age. So advancing maternal age, higher damage of the DNA. There is also a correlation with the length of the abstinence in terms of days, so increase progressively. So we know that sperm COMET fragmentation is a good predictor of pregnancy outcome if we do program intercourse, intrauterine insemination, inconsistently with in vitro fertilization, and almost never with ICSI. The benefit of ICSI seems to be attributed from the literature and the studies performed so far that the spermatozoa are not exposed to the culture media overnight, where they actually release their own reactive oxygen species. Similar, also the oocytes are preserved from the overnight exposure to the spermatozoa metabolites. So, nonetheless, if you have a DNA damage of the spermatozoa that we inject, this may lead to miscarriage. So, we developed a clinical algorithm. So, we have here a couple that actually perform an IUI. This couple have normal semen parameter, the male partner. The female partner have a young maternal age and a negative infertility workup. So if we go to low pregnancy rate, like 1.8% in this particular study published on the Journal of Assisted Reproductive and Genetics in 2018, then we perform sperm COMET fragmentation. If this is a norm, then we proceed with standard in vitro insemination. And in fact, we are able to increase the pregnancy rate to 13%. If it's abnormal, we perform ICSI. And also for the patient that are not able to achieve a pregnancy with standard in vitro insemination, we perform ICSI as well. And we were able to get the pregnancy rate of 19%. So we have quite an improvement here. However, there are still cases that we are not able to treat. And for those, we kind of regroup and we look, in fact, what actually generated this damage of the COMET. We realized that through the transit in the male genital tract during the ejaculation, you have here that the spermatozoa have a higher chance to be exposed to the reactive oxygen species present in the genital tract, in prostatic secretion, etc. Therefore, we performed this study, published last year on the American Journal of Urology. Actually, we performed a mapping of the sperm COMET fragmentation throughout the male genital tract. These were individuals in the study where there was a high DNA fragmentation in the ejaculate, about 32 to 38%. And if we assess the spermatozoa retrieved from the vas deferens, this decreased about 17 to 23%. From the epididymis, about 15 to 16%. And from the testicle, we're able to identify spermatozoa with a sperm COMET fragmentation below threshold. The threshold for the tunnel assay used in this study was about 15%. So these are the results. We use just a simple ejaculate. In this individual, we do perform ICSI. We have a fertilization of 66%, an implantation of only 3%, and getting a pregnancy rate of 6%. Very few. But if we use surgically retrieved spermatozoa, although we have a similar fertilization rate, we have an implantation rate of about 13%, 29% clinical pregnancy rate, and 22% deliveries. So this is quite an improvement. However, not everybody would like to perform a testicular biopsy, would like to undergo a testicular biopsy. So in 2014, in this perspective on the assessment of human sperm COMET integrity, we reported there was a clear correlation or inverse correlation between the DNA fragmentation and actually the motility of the spermatozoa. So we decided to go to this device. So this device is actually a microfluidic chamber. And what it does, this is the principle, the spermatozoa are selected according to their superior motility. Higher the motility, the interspermatozoa will be collected in the upper chamber, and we use those. So we were among the pioneers to perform this study. And you see here on 125 patients, the same parameter. You see in the raw sample, you see the volume decrease obviously with the treatment. The concentration remarkably decreased whether from the raw to the density gradient and the microfluidic. However, the motility increased dramatically, goes all the way to 96%. So the morphology improves, and while the chromatin fragmentation decreases up to 1.4%. This is the motility in the raw specimen. This is after density gradient. This is after microfluid. You see a very clear superior motility. So we performed then further another study. This is kind of a comparison in the patient, their own previous cycle, are 21 couple. See the maternal age 8 years of age and the paternal age over 40 years. See 39 cycle with density gradient and 26 microfluid. See the number of injected dose. Perfect rate improved 60 to 69%. Number of cycle we transfer all of them actually receive at least one conceptors. So these are the results with density gradient. You see the implantation of 10% clinical pregnancy rate with 5% ongoing in delivery and 50% pregnancy loss. But if we use microfluidic selected spermatozoa, we have 30% implantation, increase of 50% of clinical pregnant deliveries, and 0 pregnancy loss. So, emboldened from this finding, we did another study in 55 couples. You see here the demographic, similar. The concentration also in this case, though, it increases, so the morphology and the chromatin fragmentation decreased to 3% from 22. So overall. So 69 level, you see here the fertilization rate of 76%. This almost all cycle had at least one consecutive implant. And these are the result. An implantation rate 25%, a clinical pregnancy rate of 47%, and a similar ongoing and very few pregnancy loss. Then we came across this paper. This manuscript speaks about that actually what is important in sperm chromatin fragmentation is not the single strand, but is the double strand DNA that's actually responsible for structural chromosomal abnormality. So therefore the question is, can actually the sperm chromatin fragmentation induce an embryonic DNA? So we performed this assay. This is a neutral common assay. And it's very specific of this double strand DNA breaks. Here that they compare the type of standard DNA. Here 22% in the raw sample, they reduce 18% in the density gradient, and microfluidic 1.5%. Here the double strand is about 3% and reduced dramatically after microfluidic, although still present. So we have here 57 couples that underwent PGTA for obvious reason prior to coming to our center for microfluidic. They were treated by density gradient in 71 cycles. You see here the demographic in terms of maternal age and paternal age. You see that the concentration when we treated the density gradient was 3 million, became about 8 million with microfluidic. The motility improved from 37 in the raw sample, 58 by density gradient, 97% with microfluidic. The morphology improved close to 3.3%. And the sperm chromatin fragmentation decreased dramatically to less than 2%. So when we look at the employee of the embryo by PGTA, we saw that by density gradient, they have barely 25% of the embryo euploid, but they increase or double almost 50% after microfluidic. So let's look at the result. The implantation rate was 6.7%, clinical pregnancy rate of 10%, and no ongoing on delivery. So all pregnancy losses. So when we did microfluidic, we were able to bring up the implantation to 65%. So the clinical pregnancy rate was extremely high, so the delivery rate. That was surprising, but extremely, reassuring that we could do something for this couple. So another thing we need to consider is the chromosomal abnormality of this gamete, of the spermatozoa. We studied together with other groups in the 2000, and we saw that by FISH, we were able to identify a higher incidence of chromosomal abnormality in the surgically released spermatozoa. Some in the epithelium, but mainly in the testicular spermatozoa. So we decided in 2019 to revisit this, and we published on PLOS ONE. And what we did, we looked at the 10-probe FISH, but also we performed all exome sequencing, and we assessed all the entire chromosome. You see the incidence of chromosomal abnormality here per chromosome is much higher than just a simple FISH. So this is the study where we use a control, fertile donor, and then we use here ejaculated spermatozoa and testicular by FISH. And we saw actually there was no higher incidence of chromosomal abnormality in testicular spermatozoa. Therefore, we performed NGS, and actually we noticed that there was no increase, we confirmed there was no increase in the testicular specimen, but it was actually higher in the ejaculated spermatozoa. So in other things, we try to identify couples that have complete or almost complete absence of fertilization, even with ICSI. That's a paper we recently presented on, published on fertility and sterility. So the algorithm works in this way. So if a patient has a fertilization of less than 10%, we perform a PLC-zeta assay. The PLC-zeta is claimed to be the activating factor, the soluble activating factor, present in the perinuclear thicket of the sperm head underneath the acrosome. So if the PLC-zeta is present, then we just tweak the superovulation protocol and we see if we get better result. The PLC-zeta is absent, then we perform mouse oocyte activation test. And it also this confirms the finding, we perform a cis-gamete treatment, and in this individual also genome assessment. So this is the PLC-zeta assay. You see on the right here, that is equatorial, on the apex of the sperm head. I frame it here, and this is a merge, but if you remove the DAPI, you'll see clearly where the PLC-zeta is located. So these are the oocytes with the deficiency, and you see a 52 couple. These are the demographic. You see the result. This is the control, the same cycle and the same couple. You see the fertilization was only 2% with no chance of pregnancy. But tweaking the superovulation protocol in relation to a previous study that we performed, where we look at the cytoplasmic maturity of these oocytes in order to give enough time between the HCG and the egg retrieval, the HCG and the removal of the cumulus, as well as the HCG and the timing of ICSI. So we got a fertilization rate of 59% and a clinical pregnancy rate of 33%. Then, if these are PLC-zeta absence, obviously very intuitive, and these are the 24 couple included in the study, 27 cycle, the service control, where was done no site activation, 9% fertilization, but with assisted gamete treatment, which included the exposure to an activating agent of the spermatozoa and the oocyte, we got 42% fertilization and 36% clinical pregnancy rate. I think it is fair to also share with you the data we performed in assisted reproductive technology from Cornell in the last 27 years. We performed so far 59,000 cycles of ART. The large majority is ICSI, over 90%. And this is the procedure. And you see of those ICSI of 43,000, about less than 10% were surgically retrieved spermatozoa, the large majority with ejaculate. These are 39,000 cycles. You see the maternal age, 38 years old, with a big standard deviation. You see the semen parameter, only about 15 to 16% abnormal. All the other ones have at least one abnormal semen parameter. We perform ICSI on 340,000 oocytes. Likely 97% of them survive, and of those, 78% displayed 2PN. There was about 2 to 6% of abnormal fertilization between 1PN and 3PN. If you look at the source of the ejaculated, whether ejaculated or electroejaculated or retrograde, you can see that the fertilization was between 74 and 76%. The clinical pregnancy rate between 36 and 46%. This is our data with testicular. So if you see the fertilization rate between fresh and cryopreserved ejaculated, is similar at 75%, epididymal over 70%, and testicular is close to 50%. See, there is no difference in green between the fresh and in blue, the frozen specimen. However, if you look at the clinical pregnancy rate, epididymal has a clinical pregnancy rate about 60%, the testicular about 40%. If you look at the cryopreserved, is somewhat inferior to 43% for the epididymal and 36% for the testicular. However, there is significant difference between the epididymal and testicular, although they have different indication. But if we look within each procedure, the fresh specimen outperform the cryopreserved equivalent. So these are overall results with standard in vitro insemination performed in these 27 years. You see 60% fertilization with standard IVF, only in ideal couple, obviously. The clinical pregnancy rate of 40% and 35% delivered. If we look at the ICSI, we have a higher fertilization rate, and the fertilization, however, is on the metaphase 2 oocyte. If we correct for the retrieve oocyte, you see the two procedures overlap perfectly. However, ICSI is more versatile and can be used in couple. The standard in vitro insemination cannot. We have so far over 21,000 baby born at Cornell in these 27 years. Another selection that we perform is the gender selection. Here you see the semen parameter pretty much normal. And you see that we can enrich the specimen whether for male or female, X or Y, and then over 80%. This is the couple 52 and 70 cycle. These are the demographic, 38 is the maternal age and over 40 the paternal age. We confirmed 43 PGDA embryo here. The couple were 82%, embryos, where 82% actually had the desired gender. We were able to confirm the enrichment of the spermatozoa. 29 cycle had the replacement, and a clinical pregnancy rate of 62% with 51% delivered. We look for the male here, we got about 86% the confirmation of the embryo, and we 21 the cycle we transfer, and a pregnancy rate of 14, so 67% similar in the delivery. So we went even further to try to see if there were other characteristics by weighing the genome and the epigenome of this individual. This is a comparison also presented in +1 in 2018. When we compare individuals with normal semen parameter and the female pattern of with a young maternal age and negative infertility workup, we compare the mutation in a control, in a fertile donor control, and we have this individual that actually came to our clinic where we were able to achieve a pregnancy after ART, and you see that the number of mutation, duplication, and deletion are very limited. Means that those that were not able to have, so the so-called infertile, the number of duplication and deletions are remarkably higher. So we also look at the gene product in each compartment of the spermatozoa, whether in the acrosomal, nucleus, centrosome, etc. And we saw that the gene product present in the acrosomal vesicle and those in the flagellum actually correlate with fertilization and motility. So these are all ongoing studies at our center. We're also working with a unit in Ithaca, the main campus of Cornell, where we're trying to use microfluidic to identify a better way to select spermatozoa for our needs. So we have here some sort of corral, and it's actually the video. You see, the spermatozoa, they swim on the opposite direction of the flow, in this case come from the right to left. They're collected here in this area, and so they have superior performance. More recently, we explore another characteristic based on the structure that there is in the isthmic portion of the tube, and we saw the spermatozoa that actually pass through the restriction here, the structure, against the flow, are those that's more capable of fertilizing. And these are all studies ongoing, and actually we got offspring from the assessment of this microfluidic device in the mouse. So we can conclude that it is important to assess the genomic integrity of the male gamete, Now we can confirm that the male gamete had a 50% role in generating the conceptors for a successful pregnancy. We know that the single or double-stranded DNA damage affects embryo implantation, and this is due to the oxidative stress present in the male genital tract. Fortunately, we can do something about by using testicular spermatozoa or microfluidic sperm selection to yield desired multi-spermatozoa or with the best genomic integrity. Gene studies are very important to clarify the etiology of this rare form of male infertility, and chip technology are helping us to identify the ideal spermatozoa that we can use for the injection. And these are all the collaborators here at Cornell that helped me out in putting together this study I can share here with you. Thank you.